Welcome to another edition of Healthcare STARcast. And we truly have a star today. My friend, John Gorman, an industry thought leader, a serial entrepreneur, a lot of people in the industry. He doesn't need any introduction. John, I'll cut to the chase. Welcome to the Healthcare STARcast. I've been looking forward to having you and having the conversation. Welcome, man.
Me too, Subbu. Thanks so much, brother. It's great to see you again. It's been too long.
It's been too long, and there are a lot of things going on.
A lot.
Yeah. So we're recording this conversation August 19th, and we are in the stretch of finishing off the year. The big, beautiful bill passed. From a policy standpoint, there are other policies that are coming down the pike. But I think I will start, John, for context, right? John, you've navigated so many policies yourself as a leader for your companies that you've led, Gorman Health Group, Nightingale Partners, etc. You've also helped many organizations across the nation, not only improving efficiency of the plans. Social determinants has been a focus. I think you talked about social determinants of health even before it was a thing,
About
So
10 years ago, we started talking about it.
yeah, so I was fortunate our paths crossed back in the day when we partnered together, when I was at, Independence Blue Cross and many other places we, crossed paths, obviously. So put things in context, right? The way I see, in the policy environment today is there is a star rating pressure. Obviously, this has been talked about at this time of the year, by everybody, right? Lots of unknowns. Risk adjustment data validation audits, which we'll jump in a little bit more, and then cost pressure on top of that, the impacts of the big, beautiful bill. So give a high level view of how different this is from decades compared to decades of several policy changes.
I can tell you, Subbu, in 35 years of doing this here in DC, I have never seen a bigger shit sandwich delivered upon the American public than the big, beautiful bill. This thing is a full-blown assault on healthcare in this country. And, I think a lot of us in Medicare Advantage have thought that, we didn't really need to worry too much about this legislation because it was mostly focused on Medicaid. But I think that's a really sheltered perspective, because there are direct assaults on Medicare, which we'll talk about in just a second in this thing. And I think it's worth noting that, these changes to Medicaid will have massive impact on Medicare Advantage, if for no other reason than what it's going to do to dual eligibles. The dual eligibles, obviously, these are folks that are eligible for both Medicare and Medicaid. So these are low-income seniors and the disabled. It's estimated that up to 1.5 million of these people are going to lose their Medicaid coverage altogether. These are the most vulnerable patients in the entire health system.
Yeah.
And from a business standpoint in Medicare Advantage, they are more profitable than any other segment that we serve. So that's a direct broadside to Medicare Advantage. And then if you look, beyond the legislative text, Subbu, what nobody's talking about, and it scares the shit out of me, is that because this bill blew through the debt ceiling so badly, we are going to trigger, if you remember this word, sequestration.
Mm-hmm.
And starting in January of 2026, unless Congress intervenes, we are looking at 4% across the board Medicare cuts to help finance this tax cut for billionaires. And I don't have to tell you, of all people, that a 4% across the board cut, if that's allowed to go through in January, is absolutely catastrophic for our industry, and nobody's talking about it. So that's been kind of baffling to me, that we're waiting on the largesse of Congress, which has expressed some serious reservations about this program since Trump got reelected. So, from the standpoint of how big is this a change, It's the biggest one I've seen in 35 years, even more than the Medicare Modernization Act that W passed. I mean, this, nothing even comes close to the damage that this is going to do to our health system. And we have to look, even a little broader. What else is in the bill that will affect seniors and the disabled?
Yeah.
I mean, these were the biggest cuts to SNAP and to food stamps and to food aid in the country's history. Millions of seniors depend on these programs for help. So we're going to have a hunger crisis again among our seniors, where these folks are going to be eating dog food and cat food at the end of the month when their Social Security checks run out.
Yeah.
And then you look at what Elon Musk and Doge did to other federal programs that we care about. They absolutely annihilated, for instance, the LIHEAP program. That's the Low-Income Heating Assistance Program that provides subsidies for low-income people, including, again, millions of seniors and disabled people, to help pay their utility bills in the summer and the winter, which means that literally millions of seniors and disabled folks could be living in homes that are uninhabitable in the summer and the winter. They gutted the HUD Section 8 housing subsidy program, again, which millions of seniors depend on. So we're gonna dramatically increase housing insecurity among our elders. They absolutely, decimated the VA, which Medicare Advantage makes a lot of money off of veterans, because so often these guys go to Veterans Administration facilities instead of in-network care, and then that gets paid for by the VA. And so it's kind of like almost like double dipping for MA plans to serve veterans. And now we're going to start to see all kinds of out-of-network claims from veterans that can no longer get service from their VA facilities. So, I mean, when you start to look at it from a broader lens, this is a war on the poor, man. And the poor are really the lion's share of the membership in Medicare Advantage. So this is the scariest time I think I've seen in this program.
Yeah. And John, thanks for that perspective and making it real, right? There's the poor, and then there are so many percentage of Americans, and especially Medicare eligible folks, are in the cusp of being poor, right? That percentage of members who are trying to go drive to Social Security office, which may be shut down in the local places, and trying to reconcile stuff, right? And then they are actually going through hoops of AI IDR triage, and they just don't have time to kind of navigate this stuff, right?
And now, there was a study out recently that showed that given the Doge effect on Social Security, most seniors in this country are now going to have to drive an extra 100 miles to an actual Social Security office that's still open to get this kind of service. So, from where I sit, Subbu, the really scary thing about this is that all these changes happened after the bids for 2026 were submitted.
Yeah.
And none of this was factored into most of the bids that, the plans that I spoke with.
Yeah.
And so that means that benefit design in 2026 could be really out of whack with what the reality on the ground is for the millions of members in Medicare Advantage. And there could be, a real ugly awakening for this industry in 2026 as a result.
2026, yeah. And John, if I'm a health plan executive listening to this, right? So all of our, people, our friends, right now, you got, as you painted the picture here, 2026, you got the 4% sequestration impact, which is may or may not be accounted for, most likely may not be. And then you got the risk adjustment data validation audits clawback. Right now, I mean, RADV audit has been the talk in the last few months, but in the clients that we engage with, I engage with and you engage with, and I directly support the RADV work, right? But I engage with is right now, the clawback has not happened. So that will happen soon.
Next
And
year or the year
next year or year after. So 2026 is the year where rubber meets the road, really, right? So we painted this picture. I know it's a hard time, and add on top of it a layer of AI, which adds an extra dynamic, to this. I want to shift our conversation to, okay, we are here now. What can we do, right? So what can health plans do to, one, we are sitting in August, plan preview happening for star ratings. I predict that it's going to be challenging like last year or even more. I mean, cut points getting harder. There, the study from JD Power came up today, just before, we started this call. The whole satisfaction of enrollees with Medicare Advantage is even getting harder to kind of get the trust. And that's really the gist of it in a way. And for folks who are listening to this, we'll put this link to the actual study. But I think there are signs that people are not happy in general. The trust is going down, with MA a little bit. At the same time, we have a booming demand for MA, at the same time, right? What can, help plan leaders do, right? If I'm an executive, C-level executive right now, right? We know, hey, some of these, we don't know what's going to happen in 2026, how it's going to, rubber meets the road. So we really have to think about 2027 now, and then really do blocking and tackling right now until new benefit structure can be put in place. Share some of your thoughts. What are the big ideas, and what are the things that people really don't talk about?
Well, as we're already seeing, Subbu, in the sort of the strategic layer of thinking that's going on in the industry, we already see, a number of the big nationals that are already starting to get out of the PPO business. And, that's always a great bellwether or canary in the coal mine for, the overall health of the industry is, when you see a retreat back into tighter network models and a retreat away from more open access PPOs and other products like it, that says that the industry is getting very worried about cost and revenue on both sides of the ledger. And at this moment, it's standing at about 2 to 3 million beneficiaries that are going to lose access to PPOs altogether. And that's, a response that you can hardly argue with, facing the headwinds that we're looking at today. Next, I think when you start getting into the thinking, from where I sit, I think we need a real rethinking of benefit design in Medicare Advantage. Given all of the things that we talked about earlier, Subbu, with everything from food aid to housing subsidies to the massacre at the Social Security Administration, it really says that MA plans really need to get back to basics and kind of think about Maslow's hierarchy in benefit design now, right? And with all of this other stuff that's going on and recognizing how vulnerable seniors are, basically they've shredded the safety net for vulnerable seniors in this country. I think benefit features like, I hate to have to say it, but silver sneakers and gym memberships and, that stuff may be popular.
Yeah.
But that's not where the need is right now. Plans doing wearables and stuff for the worried well. I think a lot of this stuff needs to get jettisoned, and we need to really rethink the bottom layer of Maslow's hierarchy of the basic needs of human survival. We need food, we need shelter, we need transportation security. All those things need to become priorities in benefit design. And if those things are lacking in your 2026 benefits, now's the time to start thinking about a mid-year benefit enhancement, which, by the way, the plans can do instantaneously without CMS approval. That's something to start thinking about. Or to start imagining these as administrative benefits that you're not getting Medicare to pay for, but because the return on investment on food security, housing security, transportation security are multiples of what it actually costs the plan to provide the benefit, that you really may want to start thinking about these things as administrative benefits in 2026 just to meet the need, because otherwise we are going to see, especially in rural and in inner city urban communities, ERs are just going to get hammered next year with all these changes that have come down. And we certainly don't want our members stuck in a busy ER because they don't know where their next meal's coming. They can't couch surf anymore and they don't know, where to go except for the street. Or they can't get to a pharmacy or to their doctor's appointment, or God forbid, their dialysis. Those are the kind of benefits that I think the industry's really got to get recentered on very, very quickly. Then when we get into operations, Subbu, one, I think the plan's got to be really looking at the administrative costs on the ledger, once again. And the biggest expense that plans make of themselves that does not pay off in dividends is prior authorization.
Yeah, absolutely.
And it's the thing that members hate the most.
Yeah.
We end up approving 95% plus of these services that we prior auth anyway. And it's like, why are we doing this? We're putting ourselves through these huge head counts of people doing these reviews and then end up approving them anyway. And it makes the members hate us and the providers hate us. I think it's come to Jesus time.
Yeah, big time. I think the last few months, right, especially after, the, CEO got, suspended. I mean, I think things are brewing prior auths. One of the things, John, I think you hit hit an important one is the satisfaction. It all makes, for all of us as humans, like we all have gone through this ourselves, for our parents, whatever, right? For ourselves, grandparents, you name it. All right. But I think one thing I don't see that much, and I keep talking to the industry and my potential clients, my clients right now about this, is the connectivity of prior auth to the quality side, the stars side,
Certainly on the CAP survey,
and then the whole risk adjustment side also, right? Because I think prior auth historically is being like, okay, there's a clinical medical director and a new team, it's all them, right? But it's really I don't see many people connecting the dots around the prior auth. That's something that, I try to push as much as possible with the team. But I think the way you talk about it here, right? So it's one of the member, they're going and they're trying to hit, go to the ER or going to other doctor, and then they hit by a prior auth. They're so unhappy. They're not they're not able to kind of go to another doctor's office because they don't have enough transportation to get there, right? So I think there's going to be more and more stories, to your point, John, coming out later this year and early next year around the real impacts of the bill.
It's so wasteful the way that we do prior auth today.
Yeah.
And when it's pissing off your members, it's pissing off your providers. And it's gotten to the point where we've got folks in Congress talking about another Patient Protection Act, that it's gotten so bad. It's time to rethink it. And I think the problem that we have is it's just so deeply entrenched in what this industry does.
Yeah.
That I think it's going to take some time to get around the old heads in the industry, if you will, Subbu. We think how we're doing.
Rethink how we do it
is almost the perfect application of some AI engines to do this stuff better and more efficiently.
Yeah.
And, I think if we just went about a systematic rethinking of how we're doing prior auth, that the entire industry will be better for it.
Will be better for it.
It just doesn't save the money. Most executives think that it does. And it's the biggest, fish hook in the mouth of members and providers that, it's really time to rethink it.
Yeah, it does feel that way, right? It does feel that way.
I think another thing that we've got to get much, much better at is provider network accuracy and, understanding really who's in our network and how our members are finding their way to these providers. And the trouble that a lot of members in these MA plans have with inaccurate provider directories. I mean, that's another major cause of dissatisfaction with this program. And it's basically just sloppy administrative stuff that results in it. It's relatively simple to fix. You and I did this stuff at Gorman Health Group, all the time in those years. And, there's such an easy fix to this problem that it's time, the industry really got on it.
Yeah, totally. And then the whole application of the interoperability mandate to it. And I think I'm an optimist, John, you are too. No, but at the same time, like interoperability is always thought about an IT thing, right? It's a business driver to all the things that you talked about is an interoperable system.
Of course.
Right? That's awesome. That's a high level, just putting it in a nutshell, right? So
Down into
looking
operate.
at benefits,
Yeah.
looking at benefits, whatever you can make ad hoc benefit changes right now, right? So that you can take care of blocking and tackling for 2026, regardless of the size of the population one is managing. And then using that as data to put something together more robust in 2027. And I know, John, you put a lot of thought leadership stuff out there. They're in podcasts, you're in LinkedIn, etc. So I think I encourage the listeners to kind of like follow John, around this as well. And the thing that you mentioned is outside of the benefits is the development of the ecosystem to make it, crush the change the game on the interoperability piece and really take care of the social needs that and get to know the members, even better, in the community.
Absolutely. Now let's get down into the finance layer, right? We know Dr. Oz is on this crusade around risk adjustment. He's hiring 2,000 coders by September. I wonder how that's going. Yeah. But his promise is that he wants to audit all of the plans, do a RADV audit on all of the plans in the upcoming year. So, here's another come to Jesus time is around risk adjustment and, the reliability of the data that you've submitted to CMS and, what do we need to be doing around that data to ensure that it's accurate? This is the one true record test that every plan in the industry is going to go through. And, this is really about trying to get your risk adjustment operation down to what is accurate, complete and accurate reporting and not playing these upcoding games that, like the Wall Street Journal expose on United laid out that is, a standard industry practice today. So, we've really got to buckle down on that stuff because, the time has come now where the feds are going to be looking at everything. And, the last thing you want splashed all over your local headlines is that, we got nailed for a clawback payment in, the 8 or 9 figures that indicates that there was, upcoding at best and gaming of the system at worst going on at your plan.
Yeah.
So, I mean, this is a full employment act for guys like you, Subbu, that help do these, these mock RADV audits and help them prepare for these things because, this is now a certainty that they will happen at some point in the next 12 months.
Yeah, absolutely, John. I think right now, as you know, me and my team through Audit was supporting many customers going through RADV cycles, preparing them to have a robust process in place in the future. It's now 35 sample, right? They're going to increase it to 200 or, even more, depending on whether they're able to hire those coders or not. Every medical record, John, to your point, matters here, right? So, outside of the RADV work, OIG just last week added risk adjustment to the work plan again. right? There's the No Upcoding Act that may come up
It's coming from Congress. Yep.
Congress in fall, right? So just around coding, there are three big things, going around.
It's so bad, Subbu, that this was about the only thing that Project 2025 mentioned about the Medicare Advantage program was that payments got to get fixed, if for no other reason than to just find pay-fors for this billionaire tax cut.
Yeah. I mean, I think it's always we've seen another, it's a different situation. Every time when there is crunch going on in a health plan, people look at the risk adjustment revenue, right? So now it's in a bigger way, from a CMS standpoint. It's like, okay, where can we get the best money out of it? Okay, wow, this is where you can quantify things. Here's where you can claw back. I think this is, while it's going to be challenging because they're going back to previous years. You don't know whether those providers had a medical record, right? Because plan operations are more built to look back just a couple of years and then probably a year, and then work on doing things moving forward. So it's a big dynamic change to the plan operations. And it requires a new way of thinking, as you mentioned, right? So the old way of thinking on prior auth, the old way of thinking on risk adjustment, the old way of thinking on star, and costs just needs to kind of completely vanish and move, move forward.
And, for what it's worth, Subbu, the last two presidential budgets that have been submitted accounted for, I think, around $800 million in clawback payments once this stuff is fully implemented. So in the context of a $500 billion program, that's obviously peanuts, right?
Yeah.
But for the plans that it happens to, if you're United or Humana, it's the cost of doing business. If you're a local or regional powerhouse, like, the plan I'm on the board of in Detroit and a few of those others, the members of ACHP, the Alliance for Community Health Plans, that could be devastating. So that can't be underestimated, even though the aggregate numbers are not all that big and scary. It could be very big and scary based on if you're one of those mid-tier plans.
Mid-tier plans, yeah.
It, could barely suffer one of these clawback payments. But I think it's a much bigger issue in the context of what it looks like in your local press, and then what that in turn would do to your star ratings as a result when people. Yeah.
No, John, hearing this, right? So I think these are bigger things happening in the industry, right? So all these things, folks like us, executives, we kind of like think about all these. I'm putting myself in the shoes of middle management operators who are actually facing day to day, looking at the population, talking to members, right? So I think just kind of like to empathize with those folks here, right? What beyond the C-suite, these are big C-suite decisions, right? So, and beyond that, what should these folks be focused on right now?
Well, in addition to the stuff that we talked about, I mean, look, fixing provider directories isn't necessarily a C-suite. I mean, it's a C-suite issue, but it's going to get handled by folks in middle management. I think looking at where star ratings is going is critically important. I think, one, it hasn't been said yet, but I think it's a virtual certainty that the forced march we were all on into the health equity measures that were planned during the Biden administration, that shit's not happening.
Yeah.
These guys have declared war on DEI or anything that looks like it. And just, the phrase health equity is persona non grata within the walls of CMS right now. So I don't think any of that stuff's going to happen. And we'll see that in the next program guidance that comes out probably in the spring of 2026. And I think what they'll do is just revert back to the member experience measures that we're all familiar with, and that frankly came out of the first Trump administration, if we remember.
Yep.
The ARABs, so, 2/3 of the rating being attributable again to the member experience says, we really got to start thinking and putting ourselves in the shoes of the members. And what are the daily blockades that we're running into in our access to care and services and benefits, right?
Yeah.
And we talked about some of them already. Provider directories got to be accurate. You don't want your members going off to some strip mall where some doctor spends one day a week at this clinic and they show up and he's either not there or that location has been closed for months. And, so these folks are showing up for these appointments and not getting care. You think about their ability to access their supplemental benefits. I mean, there's a lot of this stuff that's made available to these members that they may not actually be aware of being available to them. And if we start responding more to the whole Maslow's hierarchy piece we talked about earlier, right? And we do those as mid-year benefit enhancements or as administrative benefits, then it's critical that you got to notify the members that are eligible for those services that they're there.
They're there.
Because
that's the way we do that.
Big audit that Dr. Oz said he was going to start getting into is how much of these supplemental benefits are the members actually using? Are these just window dressing for the plans during open enrollment, or are these actually, weapons that the plan is using to really try to restrain cost and to improve quality? And, the member uptake of those benefits, especially if they're not in the bid and all over your materials come open enrollment, I think is going to be a real challenge for the plans if they go that route, and they should. So it's not just making food or transportation or housing available to certain members of the plan that are desperately in need of them now. It's going to be, did you make them available? Did you assist them in accessing those benefits? And what was the throughput on the folks who actually used them?
Yeah. Well said. I think, what this reminds me of a focus group I did, John, years ago with a few members, right? So we were all talking about, I was in the health plan side at that time, and we were all like talking about, here are the awesome benefits we have, transportation, food, you name it, right? Gym membership, etc. And there were a couple of people who actually opened my eyes in a different perspective, right? These members were, I don't care what benefits you have. If it may be a transportation benefit, but I am looking to go to the doctor's office. I'm not looking for a transportation benefit. I'm looking to go to the doctor's office. I am looking to go get food on the table. I am looking to get A1C tests whenever I can, wherever I can, right? It's just a different kind of perspective of like how, they're looking to do this. I think what you said is the throughput and the language that is used to kind of really kind of engage with the members in the community in a way where we actually understand where they're coming from. So rather than like, hey, here you go, hey, flashy material, but no, we can help you to get there.
Yeah, absolutely. I think that's going to be critical. There's just going to be, a lot of busy work that has to go into making sure that the benefits are aligned with what the needs of the enrolled population are, and that those folks are aware and assisted in getting that help, because they will need it next year and the years to come of this administration more than they ever have.
Yeah.
And this is why I love focus groups, right? Because you can never know your members well enough. And with the safety net of this country absolutely shredded by this legislation, we need to hear from our members more than ever about what they need from us, because we are going to be the ones that they come running to when their local food bank closes, or when Meals on Wheels shuts down because Trump nuked the community development block grant that gives them their money. I mean, I think Meals on Wheels one of the most storied brands in American history.
In America, yeah,
Their days are numbered.
yeah,
I could see Meals on Wheels like out of business in 2 years at
yeah,
the rate that they're going here.
yeah,
So, all of that says, with literally the ground shaking under our members' feet, it's time to get in touch with these folks in ways that we may have never been in touch before. And I think the most important folks that we're going to have on our staffs going forward are going to be folks doing member outreach, member education. I think, the staffer of the future is going to be a community health worker who gets assigned to our complex members and helps clear the rocks from the road so that they can get the services that they need and they don't end up in an ER when
right,
you don't want them there. All of that says that even the more entry-level positions within a health plan are going to be more critically important than ever.
yeah, yeah. Awesome. Well said, John. So just taking this up to a level outside of the blocking and tackling here, right? There are lots of things going, we talked about the blocking and tackling. We talked about like all the different things. This is where leadership comes in, right? I see this is a moment where there are people who are really frustrated or people who really kind of like stand up to the moment because there are so many challenges where leadership matters even more.
Yeah,
right.
absolutely.
There's courage needed to kind of like stand behind the membership and say, I'm going to put this benefit no matter what the ROI is. I'm going to test this out and then see what comes out. I'm going to learn more. That requires courage, proactive moves, purpose, etc. So your thoughts around that, John, and you are one of them. Your thoughts around how you are, what would you say to other leaders at this moment in corralling their teams together, their pals together, and beyond the policy? And there's a policy angle to it, but at the same time, beyond policy.
Yeah. Well, I mean, this is going to be one of the most challenging periods in the history of this program, no question, Subbu. And you said it exactly right, that this is going to require courage and leadership. I mean, this is uncharted territory that we are in right now. And so I think, leaders in the space got to move with purpose. We've got to, I know the mantra of the industry in times like this is going to be margin over members, but without the members, there ain't going to be any margin. And so we've got to make sure that we're holding on to the members that we've got. So retention is going to be more important than ever. I mean, who wants to be sucking up $2,000 to $2,500 per member acquisition costs in an environment like this to replace the members that you're losing? So, and, it's a time where we have to question, fundamental cornerstones of what this industry's been about. Tight provider networks and prior authorizations and utilization management, and realizing that tight networks have their advantages, but we got to get those networks cleaned up. We've got to be on good value-based contracts with the providers that are going to stay with us, recognizing that this is apocalyptic times for some providers like rural hospitals after what this bill did to Medicaid and what it's about to do to Medicare unless Congress intervenes with sequestration, and making sure that we can meet them where they need us to meet them in order to remain in these networks a long time, because nothing pisses off members more than volatility in a provider network.
Yeah, especially in a rural environment where that's the only provider they go to.
Yeah, exactly.
Right.
So that's certainly one thing we've got to be thinking about. We talked about prior auth and utilization management, and that's a systemic reform that I think this industry's really got to bear down on, because it's going to be tough for the boomer generation of Medicare Advantage leaders to rethink.
Yeah,
which is why I'm not particularly enthusiastic about these changes happening in this next 1 or 2 years, maybe years 3 or 4. we're getting there and starting to make a little progress on it. But I think the folks that really jump on this from both a member experience as well as an administrative cost item, because this is one of the biggest headcounts in plan staff is
that stuff.
is folks that are doing that's not getting you any return on investment. And, reinvesting those kinds of things into, say, social determinants benefits that can actually prevent ERs and, unnecessary hospitalizations and nursing home stays for these members. I think that's really where it's going to be at. STARS, I think, is going to be follow the best practices of the industry that, we're not heading to health equity anymore, but we're probably reverting back to member experience and all the stuff that we learned in the last 3 or 4 years around member experience and, helping members clear the rocks from the road in their access to care gets you better member experience.
Yeah, I think going back to those basics is Jonah impact stars, the data part of it is well known, right? So that's going to be always the game. Every inch matters, every data point matters, clinical data exchange matters.
And, getting more accurate and complete with our risk adjustment data, Subbu, as you know better than almost anybody in this industry, that's going to help you on the STAR side because it's all the same data.
It's all the same data.
So, when we really start turning the screws on risk adjustment, our performance and STAR ratings should get better as the data improves.
Yeah. And with the V28 model, it just gets even more specific than that. It's going to, feed into HEDIS engines, etc. So, John, such an awesome time always.
Always a pleasure.
Great catching up. I'm sure we can do a round 2 at any time.
Yeah, no, I'd love to anytime.
Just a closing thought. So the way I see it, John, is it's about time designing and moving to the future of care for seniors and vulnerable population. You said it well also in all the, aspects you covered. So where can, my audience follow you and where can we see you at conferences? Where are you going next? And any closing thoughts from you would be fantastic.
Well, you can always follow me on LinkedIn. I'm a LinkedIn warrior. I think I'm John Gorman 18 on Twitter, but I'm easy to find on LinkedIn. There's only a couple of John Gormans there. And then I'm speaking at an industry conference in London in September, and then another one in Las Vegas in September around benefit design and social determinants and stuff. And then, I'll be around in the fall as I get started with a big new job. I'll be happy to announce after Labor Day. And, I'll be out there and as visible as I can be as we sail into these uncharted waters that we're all going into here, Subbu. So I'll be around.
Such a pleasure, John.
That's been fun.
The star of the STARcast.
All right.
Thank you.
Good to see you again.